guys. I'm Nicole Rios, and I've got opinions. Today, we are going to talk about healthcare specifics as far as the structure is concerned. What constitutes a healthcare structure? What are the building blocks? What are the areas of concern that we currently need to work on? And what we should be focused on, and honestly, how the current structures that we have our healthcare based on, how those came together, how that all happened. So the first thing that we're going to talk about is this document called the Declaration of Alma-Ata, which was adopted in 1978 at the International Conference on Primary Healthcare, which was organized by the World Health Organization and UNICEF. And it was the idea of all of these countries coming together and creating a commitment to achieving health for all. And their primary focus was creating this idea of primary healthcare. Sound familiar? And so the idea of primary healthcare was that it was the cornerstone of the health systems, and that with primary healthcare, we would be able to have preventative treatment and vaccinations, and it would allow for our health to overall be better for longer. It was drafted by 134 countries and 67 international organizations. And when we think about the timing of this, 1978, we're talking like post-colonial, Cold War. This is when a lot of the whole equity, social justice, self-reliance was really culturally becoming more important and more pronounced. And so, this was an opportunity for a lot of different countries to come together and stand together on this idea that, healthcare for all should be accessible and equitable. So just to provide a little clarity, the key terms that we are going to be using today are healthcare system. So a healthcare system is a means of like organizing and delivering healthcare to achieve health outcomes. This can be with private, public components. Obviously, they are all very interdependent, but the idea is that we are going to be responding to a need of a population. Primary healthcare is the essential healthcare based on practical, scientifically sound, and socially acceptable methods. And the technology that we have should be made universally accessible to individuals and families in their communities. That allows them to participate and at a cost that the community and the country can afford. And then health financing involves, raising sufficient funds in order to provide this care, or pooling them to spread the risks, like we kind of see in a lot of our private and public healthcare systems, in order to support these systems as a whole. So just a little background on the global context, just so we can all kind of put ourselves in this place of understanding. During the 1970s, we had a lot of decolonization in Africa and Asia. The economic disparities between the North and the South were significant. There was the oil crisis. We had strained resources. And politically, the Declaration was kind of a response to these inequities that included even disease-specific programs like malaria eradication, HIV, some of these other major issues that we started to notice were affecting some populations in greater ways than others, which had a lot to do with economic instability or inability to provide these services. And so that's where, we had all of these new understandings of social determinants of health, which is described as, health isn't just the absence of disease, it's, the ability to live in a healthy way. And so we have now acknowledged, I think, like we can all admit that, there are things like our environment that affect our health, whether we live in the city or we live rurally. We are affected by more or less pollution, or our stress level in our life. Our access to healthcare is another social determinant that will decide how healthy we are for the remainder of our life. And so our access to diet, exercise, these are all these social determinants of health. And so when we acknowledge that these are part of the healthcare system, it makes it a little bit more complicated, because then we're asking the healthcare system to not necessarily be responsible for all of these other determinants, but they definitely are interwoven. So the alma mater supported what's called the beverage-like system, which is taxpayer-funded insurance. Aside from that, there's privately funded insurance, but this one felt that for equity's sake, that the beverage system was the best, and that it prevented people who didn't have access to out-of-pocket care, which was the option prior. It closed them off from access to care. So the idea was that if we fund healthcare for everybody via taxes, then everybody has access and healthcare is more equitable, which is logical. It is a thought. And so that is some of the things that we have to think about, is that there is this huge shift in the world towards self-reliance. We had a lot of developing countries that were thrust on their own into their own economies and into their own health systems and public provisions. And so this was kind of a stamp in the ground of, this is kind of the framework that we want to move forward basing healthcare systems off of. And for the countries who look to the WHO for their disease recommendations and all of their procedural outlines, this was what was laid forward for them. So in 2007, the WHO put out a framework describing health systems as 6 interdependent building blocks. And in conjunction with the Alma Ata positioning primary healthcare as the central function, the building blocks are kind of integrated around that. And so we can look at these building blocks and then assess where we're at within each section. And that helps us kind of refine what solutions we need to come up with. So the 6 building blocks are service delivery is the first. And the whole intention of this stuff is to, improve the responsiveness of a system and to expand who has access to the system. Ideally, when we become more efficient, costs go down. And so all of this is based on those ideas. And so primary healthcare is considered to be also ensuring that people have proper nutrition, ensuring that people have access to immunizations, and ensuring that people have appropriate treatment of regular common ailments, and promoting decentralized and community-based services. So this is the main difference of this kind of structure and what the Alma Ata is offering with the primary care, because we all understand our primary care to be like our main doc. And if we have private or public health insurance, most of the time, if we need to see a specialist, we have to access that specialist through our primary care physician. Now, the definition here is slightly different, because what it's saying is that these should be offered everywhere, and that a primary care physician should be within a community, and that the location of that primary care is what increases the access. America is vast. We have a ton of different environments, and one of our huge issues, I don't want to get ahead of myself, but is the workforce. And so when we have people who don't have access to good doctors in rural areas, most often it's because no real good doctor wants to live in that rural area. And so it makes it really hard for people who live there to have access. Like, you say you live in a mountain town, and the only access to healthcare that you have is a county hospital that's an hour away. That isn't decentralized care. So the difference here is that centralized care is going to be hospitals, major healthcare facilities. Decentralized care is having community-centered healthcare options, which a lot of places do, but one of our main issues in America today is still having equitable care in rural areas to ensure that people are still getting this access. Because people in those areas are not getting access to specialists the same way that people are in urban areas. And they probably don't have access to a lot of the diagnostics or the testing or the technologies that we have in urban centers either. And, you walk that line down, and a lot of those people don't have reliable transportation, or they don't have the money to pay for a bus to go into the city for the healthcare. And so we end up in a really nasty negative loop on getting access to care in rural areas. So what I think that is interesting is that in 1978, when we're setting out, we see primary healthcare as something that is decentralized. And what I can tell you, with the intention of creating universal care, and what I can tell you is that I see this as the opposite of what has happened with our ACA, the Affordable Care Act, and trying to create more of a universal coverage, is that it has actually caused a lot of our doctors to actually centralize. So instead of having our local GPs or, hometown docs, a lot of them haven't been able to make it on their own with all of these new regulations and everything that has happened with the ACA. And so a lot of them have been absorbed into big conglomerates. I have had two doctors in my lifetime that started as independent doctors and then ended up going and joining some hospital group in order to stay alive. So I really feel like that is something that has to change. A recommendation on this is to go towards more of like I have a good friend who recommends this, Aaron. He says urgent care based. If we have more urgent cares available, then they can kind of operate as primary care and like in between for emergency and more centralized medicine. So that is an interesting option. We still are going to have to walk that down the line and figure out how we encourage people to work in rural areas. Even currently, doctors who are getting jobs in rural areas are going for like $60,000 to $80,000 more in their salary than they would get in a more desirable area. So that does affect health costs, obviously. So the first one is the service delivery. Are we delivering a service? Are there people who don't have access to the service? Are we promoting health with the services that we're offering? And do people have access to treatment for common diseases? That's our first building block. That's the most, obvious one, right? We're talking about healthcare. We're talking about the healthcare. The second one is going to be the workforce. So the health workforce right now, again, as I was just saying, is a big issue in America. And we have like 15 million health workers in America, which is great, but we still don't have enough or the right ones in the right places. So this means that we need physicians, nurses, midwives, everybody, community workers, as they can be used to work as a team to help support the community idea of, this universal healthcare. And it also helps to create a health workforce that's responsive, that's fair, that can be supported by, the local community. And that kind of reinforces that primary healthcare delivery. The third one is the health information systems. This is all of our charting and back end organization, okay, that helps people plan and evaluate and assess. And so, especially with the ACA, a lot of doctors had to really get in on the health information system situation because they were now required to report everything digitally. And so we went from paper charts to digital charts, and that created a whole new aspect of economy within healthcare. And so that's another thing that's going to have a huge impact. So then the fourth one is the essential medicines. Again, another obvious one when we're talking about healthcare. It's making sure that people have access to the right pharmaceuticals. It's also making sure that people have access to vaccinations and other technology in an equitable way. This is just really ensuring general health for everybody, and making sure that, the one thing about the pharmaceuticals and the TAC is that it has a huge economic implication and trade implication. And so we have to be able to weigh out how in our healthcare system in the United States, how that plays into our Medicare, our Medicaid, and how we are being taxed to pay for all of that. And so that's another aspect. And then the last two aspects are the financing. How are we getting the money to pay for the healthcare? Obviously, we hope that it's coming from more than one area, i.e. our pocket. But who else is going to pay for it if we don't, right? So that's one. And then leadership and the governance of how this is being put forward, the policies that are written to enact these ideas, the strategies, plans of action, and which direction we go, closer to universal coverage or further away. So when we look at when we look at those building blocks, what I see in America as some of our main issues is going to be our service delivery. We have people who, can't get to the doctor for 6 months because there's such a backlog of patients, or people who can't get the referral for the specialty care, or people who can't even get to the doctor because they don't have anybody close. Those are real issues that we're going to have to figure out. And I think that we need to think outside of the box on that one. The second thing that we have to work on is the health workforce. And again, I think that the service delivery and the health workforce are two of the most interwoven of these, because if we don't have the doctors, then we're not going to be able to see the patients and provide the service. So that is something that I think that we need to focus on. I also think that this aspect of administrative tasks that have come on to the doctors really decreases their ability to see patients and causes that turnover time with the patient to go down by so much because the doctor is just strapped for time. And I think that if we had, some type of charting medical position that could follow a doctor around and be their charter or be the person that's doing the referrals or something like that, and we could afford that or figure out how to fit that into our situation, we might have better care. But then that lays back on the financing. So it's obviously a very complicated problem. The frameworks and the building blocks are important to look at, because when we're looking about how do we even move forward to restructure this, we can look at that and say, well, what do we need to do to, say, broaden the range of benefits if our goal is to get more people covered? Because listen, y'all, I get the Republican point of view that is, we don't want to give free stuff away all the time, taxes, lower taxes, smaller government. This sounds great. And again, we want Americans to be using our coverage, the American coverage. But it's not a bad idea, guys, to think that we want people to be healthy. The other thing that plays into this a lot is that at the end of the day, when people age out and we get these people into Medicare, we're paying for their healthcare anyway. And if they didn't have good primary care from the beginning of their life, or they didn't track any of their health up until now, and then they enter the Medicare system, they're going to have a lot of issues. It's going to be way more expensive to care for that person than it would have been to care for someone who took care of their health along the way. And additional to that, a lot of the people that we have in our welfare system that are on SNAP and EBT are also on Medicare or Medicaid, and that has an impact. And so all of these governmental welfare programs are interwoven and overlapped. And if we want to think about how we're going to afford the Medicare costs, we also have to encourage these people to be healthy along the way. So that does mean helping them get access to primary care. I mean, at least these doctors can help get them their regular immunizations and educate them on anything that a doctor could tell somebody that could improve their life, like a little diet information, or, hey man, you got really high blood pressure, or, hey, your blood work shows that, like, you might have cancer. Let's look at that before all of a sudden we realize it's stage 4. These things, like this preventative care, saves us a lot of money. And I don't think we get out of healthcare without spending a ton of money. Obviously, this is going to be a huge expense. Like I said at the beginning, we got 100 million people on subsidized coverage or government-funded coverage. It's a lot of people. We're not getting out of that. We're not backing out of that. I don't think it goes down, okay? We just have to figure out how to be more efficient as it goes up. And I know it's not necessarily a super popular opinion to say that I think we should have universal coverage, but what I can say is that what we have right now isn't doing the job. And if we're looking at all of these tax credits going away at the end of the year, it could be really cool if we showed up with a good idea. I would really like to be able to not have a meltdown. And there are a lot of people that will have, costs go up. I think that they're offering this interesting HSA option where it goes straight to the person. We can compete in the marketplace for our own coverage. I will always believe in capitalism and the idea that competition creates good pricing. But I don't know how that plays out in the real world. I don't know whether so many people exiting the marketplace actually has the impact, exiting the ACA marketplace to go exist in the private sector of health insurance, whether that actually improves the cost or not. We may see that risk pools and private insurance get worse. And who knows, because there are some people that with pre-existing conditions that are going to have to stay on some of these plans. And the problem with that is that then the risk pool gets really yucky and you don't have enough healthy people paying into the pot to accommodate the people that actually need the care. So that's not a good look. So the last thing that I think we need to talk about is the social protection, because there's the three dimensions of universal coverage are, broaden the range of benefits, increase the population who has access, and then provide social protection for them when it comes to bills. Okay, so social protection is in relation to not going bankrupt because you had to have an emergency surgery. And again, I think this is why are people going bankrupt in the United States on medical bills while health insurance companies are making massive profits? I am gonna. It's not like any of us go out of our way to cause ourselves such health distress that we need an emergency surgery. And I don't think that it's fair that a hospital can charge an individual who's uninsured for an emergency surgery $100,000 when the insurance company would pay 15. And to allow someone to go bankrupt in that circumstance is awful and should never happen in our country, especially because we do have the access to the healthcare that we have. Now, I think that the social protection is something that we don't have that we need. I don't know what it looks like. I don't know whether it's over a certain amount or whether or whether we pay a percentage or whether we have the ability to maybe do like a no interest loan or something in order to repay. Maybe not, loan's not the right word, but payment plan, because some of these hospitals are not even offering this. And the reality of the situation is, I don't know any random person, regular person that could pay 100 grand out of pocket on the dot. And again, we're talking about people who are already experiencing such a life stress and trigger. Like, imagine someone who goes in for an emergency surgery. Guess what? They're not working. You don't know how long your recovery is going to be. You don't know if you're going to be well after you're out. And then you have to worry about all your regular bills, not having a job, and then paying $100,000 when the hospital would accept 15 from an insurance company who has all the money to pay. I don't know. That's a hard one. That's a hard one to sell me, guys. I'm not buying it. And I don't think that we should allow Americans to go bankrupt because they were sick. So that is my soapbox, honestly. I think that social protection is the one aspect of the universal coverage that most of us could get behind. And I don't know what the funding aspect of that is or how we circumvent that. Honestly, I think it has a lot to do with the negotiated prices. These healthcare companies have all of these nice low negotiated prices, and then it looks like everything is like absolutely blown out of pocket for people who are paying out of pocket. And I think that might be a place to start, is that self-pay has equal rate as the lowest negotiated health insurance company. And that it already happens in some cases where self-pay is cheaper than what the insurance company is charged. And so I think all of that, like different negotiated rates and stuff like that, is so corrupt. Honestly, well, each thing is negotiated differently. Every insurance company has a different standing on these things. And I know that healthcare costs are different in different places. We can obviously agree to that. Like I just said, in rural areas, doctors make more. So I don't know how this trickles out. I don't know where that money comes from, but in my opinion, it's the insurance company's profits. Okay. Because how much of our money do they just sit on, and how many people who have insurance are also being denied for coverage of medications or treatments or diagnostics? It's ridiculous. So you can't say that, the coverage that we have to offer is enough. It's not. And we shouldn't be denying people based on these things. And they also shouldn't be paying more for their healthcare a month than their mortgage, especially when the majority of people are not using their healthcare on a regular basis. So that's my take, y'all. I think that, to wrap it up, I think that universal coverage is idealistic. Okay. There are aspects of that ideology that I agree with. There are aspects that aren't square, though, like the whole decentralized situation. The intention of this universal coverage was to decentralize healthcare out into the communities so that everybody had close local access. And what has happened since we did more subsidization is that we have completely centralized, and all of these doctors have come into larger conglomerates, which creates less competition in the market, um, and creates vacancy for healthcare in areas where people really need it. So we've got to address that, because there are populations that aren't getting care that we are going to pay for in the long run anyway. And I would rather have more people in America be healthy and happy now than letting them be sick and unwell until we pay for them when they're 68. Okay. And the second thing on that is that people who are happy are healthier. Like stress and not knowing if you're okay and feeling like you can't go to the doctor when you need to because you can't afford it, that causes illness. Like stress is a huge factor in heart attacks. Like there are so many risk factors for that. So I just think that this is one of those things where it pays off in the end. While we might have to pay for this now, and I don't think our health costs are going down. I think we might be able to get more efficient. I think we might be able to, create more competition that might bring costs down. But I also think that there are a few things within our health workforce and within our service delivery that we really need to focus on. And I don't necessarily think that throwing money at that problem is going to solve it. I think we need to be more out of the box. I think we need to consider something like this urgent care. I mean, I grew up in a really rural area of Connecticut, and our closest hospital was 45 minutes away. And when I was young, five, I got into a bicycle accident and I needed stitches. And we were able to go right in town to the local walk-in that was, within 10-minute drive. And I got stitched up. Now, that was 95. Okay. Fast forward to 2017, 2018. ACA went into at 2010. Okay. So this 2017, maybe 2016. I'm like 16 years old, and I got a kidney infection. I got really sick. I had a really high fever, and I went to go to that clinic and it was closed. And I ended up having to go to a walk-in clinic that was another 40 minutes away. And even once I got to that clinic, they realized that they couldn't treat me the way that I needed, and they had to call an ambulance to transfer me to the emergency room at the closest local hospital. And so it took me 4 hours to get to get before I actually got seen at the urgent care, and then another 4 hours before I was in the hospital. And as soon as I was in the hospital, they had to put a PICC line in me and basically told my parents to prepare for a funeral. So I think that there is real risk with not being able to have access to care in these rural areas. And the only reason why that local clinic didn't exist anymore was because things became more centralized. And even once that clinic closed, the next closest urgent care to me again was basically almost as far away as the hospital. And that's a problem, especially when we have populations that are at greater risk, not only because they live in rural areas, but because of, their access to good, nutritious food. I'm kind of rambling, but I think this is important. The other day, we went to, we went on vacation. Why were we going on vacation? I don't remember why we went. It was one recent vacation we had. My son, we moved to Tennessee from Florida. Florida started a lot later. Tennessee starts really early. And then you get like a week off in fall break before even Thanksgiving comes. You get like a week in October off. And so we went, it was Columbus Day. So they give you the week around Columbus Day. Now it's coming together. That's also my son's birthday. So we went on this little weekend trip. Okay. Nothing major. But we live in the Nashville area, and we drove to Pigeon Forge, which is about 3 hours away, 3.5. And we basically took like the rural route. It was very little highway. It was a lot of like central Tennessee driving. Okay. And what I can tell you is I realized that there, when we talk about this concept of food desert, okay, the idea behind this food desert is that there are places in our country that don't have access to good food and or healthy food or fresh produce, and that there are places where people only get their groceries from the corner store or the bodega or the gas station. Okay, and that doesn't really provide them access to, again, fresh meats or fresh produce. They're eating a lot of processed food that can be from the freezer or sit on the shelf for a year. And that doesn't lead to good health outcomes, guys. These are the same people that don't have access to good primary care. So we have huge populations of people who don't have access to primary care and don't have access to good food. And from my background in holistic health and nutrition, I think food is medicine. And so it's very easy for me to see that the combination of not having access to good nutrition and not having access to primary care and living in a rural area with extended travel times in order to get access to care creates a huge problem. That person that can't get food and can't get health care and doesn't feel good, that's in the middle of nowhere, is miserable. And this is a good percentage of Americans. So we're driving through rural America. And I realized after a while that like I haven't seen a grocery store in a while. And because I have my medical and nutrition background, and this whole idea of the social determinants of health in school, they really support this idea that, having having access to good nutrition is a huge social determinant of health, right? It's going to determine whether you're a healthy person or you're not. And so I notice, oh, wow, like we've been on the road for a while. I haven't seen a grocery store in a while. And the only reason I thought of this is because I started seeing a ton of Dollar Generals. Okay. So we're going, I see Dollar General. I'm like, oh, okay, whatever. And I don't notice it. Within another mile and a half, I see another Dollar General. I'm like, well, geez, maybe it was a mile and a half. Maybe we were further down the road than that, but it wasn't beyond 10 minutes away. Okay. And so I start noticing. And then, so I'm noticing the presence of the Dollar Generals, very little else. Okay. Dollar Generals, maybe gas station here and there, very little infrastructure, very little big, towns or anything built up. It's not. And then I notice there's the fifth Dollar General. There's the sixth. I'm not kidding, guys. On this drive, they were everywhere and nothing else was. So then I thought to myself, oh my God, this is where these people are getting their groceries from. This is the food desert. This is it, in all of my education. I'm new to Tennessee. I've only been here for a few months. And in all of my education, and I came from a city, okay? So all my education says like food deserts exist in rural areas and they don't have access to primary care. And I'm like, yeah, concepts. They're concepts, right? And we can accept them objectively. I can tell you, when you're driving down the road and you're looking at these communities and you're seeing how run down they are, and you're seeing the types of vehicles that are driving in them, and you're seeing the type of people that are walking out of their vehicles and into the stores, you get a sense that things are tough, that people don't have a lot of extra money hanging around, and that they are usually, honestly, obese, unkept, not well. So we finally come to a Dollar General that is rebranded as DG Market, Dollar General Market. Okay, so now I'm confirmed. The Dollar Generals are the grocery stores for this section of Tennessee. And I've got to be honest, it broke my heart. Because I know that's not quality food. Because I know there's no produce in that store. And because I know a huge part of my state is barely surviving and nutritionally subpar and almost guaranteed to be very expensive Medicare patients. And I'm not trying to sound heartless, but I'm trying to be practical, okay? If we are going to improve our healthcare spending, meaning bring it down, then we need to be able to identify that there are these other social determinants of health where we may have impact, where we could move in and create change. And it is a big problem that the healthcare industry is a for-profit industry, because I think that in itself is what creates the inequity. And prevents, again, doctors from working in the right places and providing care in areas where it's hard to live, and prices negotiated differently with different providers. There's got to be a way, guys. We've got a lot of smart people in the world. But when you look at it like that, you can see why we do have to address these problems, because again, we're going to end up paying for it. So thank you for listening to my ramble. That got extended a little longer than I wanted it to. So thanks for hanging in there if you're still with me. If you guys are interested in this stuff, leave me a comment. I would love to know if you're tired of hearing about it. You might want to find somebody else to follow because healthcare is kind of a big shtick of mine. And it's what my background's in, so I can speak from it from an educated perspective. But I'm probably not going to stop talking about it. So thanks for hanging out. If you do have background on this or you're involved in this, I would love to get an interview with you. I am putting together a series on healthcare that is going to provide different perspectives. So the perspective of a healthcare provider, the perspective of an insurer, and just kind of help people understand, because I don't think that everybody gets it. And I don't think that everybody understands how things are structured and why things are happening the way they are. So I would love to, I'm working on a longer series. And if this is your thing too, and you want to have a conversation, hit me up, put it in the comments. I'll reach out to you. Follow me on X, DM me, comment on X on the video, whatever you need to do. Get in touch with me because I'm serious about this. And I think that education is a huge access point. I think that that is the way to change the world, is to just lift people up by educating them, helping them understand so that we can bring critical thinking back to the masses, y'all. Imagine that. Who knew that was actually going to be my my end goal? All right, y'all. Have a good night. I will see you later this week.